Thank you so much, Dr. Hernández-Díaz, and good morning, everyone. It's an honor to be here to present some of the work that we've been leading on the comparative effectiveness of COVID vaccines here in the US. This is work that was recently accepted for publication, but not yet published, so this is brand new. And I hope that you'll find this interesting, not just the results, but also as an example of how emulating a target trial can help to provide this timely, actionable evidence that Miguel mentioned for decision-making in this pandemic, when we need to make decisions now, but we don't necessarily have evidence from a randomized trial to support those. In terms of the motivation for this study, what we know is that mRNA-based vaccines are highly effective, but what we don't know is which is more effective for a range of COVID outcomes and across diverse populations. What we did was emulate a target trial to provide this evidence in the overall veteran population, as well as in subgroups of that population defined by age and race, and also across different time periods defined by alpha and delta variant predominance. In designing this study, our first step was to specify the protocol of this hypothetical target trial that we would have liked to conduct to answer this question about the comparative effectiveness of the Pfizer and Moderna vaccines for a number of COVID outcomes. This approach was important for a few reasons. First, it helped us to sharpen our causal question. And second, this approach has been shown to reduce bias in observational studies by naturally leading to some design and analysis decisions that avoid common flaws. So this really provided the scaffolding for everything that I'll talk about next. In terms of the eligibility criteria, briefly, these included veterans who were aged 18 and up, who had no previously documented infection, no previous COVID vaccination, and who had used the VA healthcare system in the past year, but not in the past 3 days, because we thought that that might indicate the start of symptomatic disease and preclude vaccination. The treatment strategies to be compared are receiving 1 dose of the Pfizer vaccine at baseline, and then a second dose 21 days later, versus receiving 1 dose of the Moderna vaccine at baseline and a second dose 28 days later. In the target trial, to ensure that these two groups were balanced with respect to important characteristics, these eligible people would be randomly assigned to one of the 2 vaccines within strata of the variables that you see listed here, which include calendar date, measures of demographics, and geographic location. There were 5 outcomes of interest, so we were interested in documented infection, symptomatic COVID, and also COVID-related hospitalization, ICU admission, and death. And these people would be followed from the first day of vaccination, that is baseline, for up to 24 weeks or until one of these outcomes develops, or death or administrative end of follow-up, which in this case was July 1st. The causal contrast of interest is the per protocol effect had everyone received the assigned vaccine at baseline, as well as the subsequent second dose at the scheduled time. And risks could be estimated using something like the Kaplan-Meier estimator and subgroup analyses conducted by age and race. One consideration is that this target trial was designed to evaluate the comparative effectiveness of these vaccines in a time period marked by alpha variant predominance. We know that the Delta variant has been predominant since early July, and so to study the comparative effectiveness in the Delta era, we also considered a second target trial that was identical except for 2 features. First, recruitment was from July 1st to September 20th, so we assembled a new eligible population during that time period. And second, the only outcome evaluated is documented infection, and that's because this period that we looked at was too short to accrue a sufficient number of rarer outcomes like COVID hospitalization or death. And so having established the design of these now 2 target trials as the foundation of our study, our next step was to emulate these target trials using observational data from a national database of electronic health records. Specifically here, we had access to data from the U.S. Department of Veterans Affairs. This is the largest integrated healthcare system in the country. It's also an incredibly rich data resource with detailed information on all of the features listed here: demographics, all inpatient, outpatient encounters, medications, lab results, and more. These data are refreshed nightly, allowing for near real-time analyses, and the records date back all the way to 1999. So we have this long follow-up of patients that allowed us to characterize them with really high resolution when it comes to their health trajectories up to the time of vaccination and beyond. Briefly, in terms of mapping our variables of interest to the available data, we defined vaccination using records for immunizations and procedures in the database. We ascertained incident infections using something called the VA COVID-19 National Surveillance Tool, which is an algorithm that integrates information not only from the structured data on lab test results, but also from the unstructured data in clinical notes using natural language processing. And this allowed us to tap into information on documented infections, not only within the VA healthcare system, but also outside of it. For symptomatic COVID, we define this as having one or more of the listed symptoms documented within the VA healthcare system and within 4 days of infection. And these symptoms were ascertained using the listed domains. For COVID hospitalization, we define this as a hospital visit within 21 days of infection. COVID ICU admission was an ICU admission nested within a COVID hospitalization. And lastly, COVID death was defined as a death within 30 days of infection. So having established this mapping to the data, what we did next was apply all of these same eligibility criteria that I mentioned as part of our target trial to individuals in this database. And this left us with about 370,000 Moderna recipients and 400,000 Pfizer recipients who were eligible for subsequent analyses. To emulate the stratified randomization of the target trial, we took these eligible Pfizer and Moderna recipients and we matched them in a 1-to-1 ratio based on these matching factors listed here as potential confounders. And this left us with an analytic population, so a matched cohort, that had about 219,000 people in each vaccine group. Given that we're using observational data, a key challenge is the potential that these 2 groups may be imbalanced with respect to important risk factors for the outcome. And we know that this could lead to confounded effect estimates. One note here is that this confounding concern might be slightly smaller when we're comparing 2 different vaccines to one another than it may be when we're comparing vaccinated with unvaccinated people. But even so, there are a number of things that we did to provide some assurance that these 2 groups were indeed balanced. First, after we matched them as described, we generated this covariate balance plot to confirm that the 2 groups were very well balanced with respect to measured variables that included not only the matching factors, but also other known risk factors for severe disease. We also incorporated 2 negative outcome controls into our analyses. So these are alternative outcomes not affected by vaccination, but that might be similarly confounded. Specifically, we consider risk of symptomatic COVID in the first 10 days after the first vaccine dose. This is a period during which we expect no effect based on evidence from randomized trials. We also considered risk of non-COVID death over the follow-up, and in both cases, we see no separation in the risk curves for the Pfizer and Moderna groups as expected. And so given this reassurance, we then proceeded with our analyses where I have our primary finding at the top of this slide. That was a lower risk of all studied COVID outcomes for the mRNA versus Pfizer vaccine. Here I only show the risk curves just because of the pending publication, but we can take a closer look at what we're seeing here. Starting with documented infection over a 24-week period, what we're looking at are estimated risks of about 5.8 events per 1,000 people in the Pfizer group versus 4.5 events per 1,000 people in the Moderna group. So what can we take away from this? First, these risks are very low in both groups, but a little bit lower in the Moderna group. Briefly, we see the same pattern for symptomatic COVID hospitalization, ICU admission, and death, where I'll note here that these estimates were similar in subgroup analyses by age and race. We also saw that this pattern was similar in a time period marked by Delta variant predominance, though these estimates were less precise due to a smaller number of eligible people for these analyses. And so the key takeaways from this study, first and foremost, the estimated risks of the studied COVID outcomes were low in both vaccine groups, regardless of the vaccine received, confirming that both the Pfizer and the Moderna vaccines are highly effective, and they're both strongly recommended to any individual who's given the choice, potentially, between the two. That said, this study also provides evidence for a lower 24-week risk of the COVID outcomes for the Moderna versus Pfizer vaccines over the study period. And so even though those identified differences were very small on the absolute scale, they may be meaningful when we consider the larger population scale at which these vaccines are, of course, being deployed. And so this information may be helpful to larger decision-making bodies. However, that kind of decision-making, so any choice between the two vaccines, has to also consider their comparative safety, which is not something that we evaluated as part of this analysis that I just presented. But it is something that we are actively investigating as part of a separate analysis that I'm co-leading with Aaron, who you'll hear from later. So we hope to provide additional evidence for that as well in the near future. And so with that, I'd like to acknowledge my study team. This was very much an integrated effort between the CAUSALab and the VA Boston, and really just the product of some incredible teamwork. So thank you so much for your attention, and I'm happy to take any questions.
Thank you. Any questions from the audience? We actually have a couple of questions from the Zoom audience. One by Kunjal Patel is that in the randomized clinical trials, we consider the losses to follow up, and the question was, how do you regulate the losses to follow up in the observational data?
Yeah, so that's a fantastic question, thank you. So our analysis in this veteran population is a little bit unique. So veterans generally receive all of their health care through the VA. And so loss to follow-up in the sense of leaving the healthcare system was not a big concern in this particular analysis. In other analyses, people naturally in the data may be lost to follow-up, and we may apply some method, for example, inverse probability weighting or marginal structural models, to consider counterfactual risks, say had nobody been lost to follow-up.
Thank you. We have another question in the chat, and that is, why did you choose matching versus standardization or weighting in your analysis?
Thank you for the question. So in this case, we were interested in matching eligible recipients of each vaccine to achieve really tight confounding control. We did one-to-one matching. There are other procedures that may also have been adequate in achieving the balance that we saw, but this appeared to be one of those.
I had actually one question. why would the two vaccines be different? Are there any differences between them that make you think that they might have different results?
Right. Yeah, so both the Pfizer and Moderna vaccines are mRNA-based vaccines, but there are some differences between them. For example, the mRNA content is different, so it's a little over 3 times higher in the Moderna vaccine at 100 micrograms compared with 30 micrograms with the Pfizer vaccine. Another difference is the time interval between the first and the second dose. This is longer with Moderna at 4 weeks compared with 3 weeks for Pfizer. And there are a few other differences in their composition. And so it's not immediately clear which of those may be important for risk, but just highlighting a few that may be worthy of further evaluation.
Thank you. Anybody from the audience, one final question? Oh, there is a question, yes.
I didn't see all the matching criteria. Was site of care one of them?
Yeah, so that's a great question. So we were definitely interested in achieving tight control for some measures of geographic location. And so the way that we approached this is we started out by matching on VA station, so the actual medical center. And then what we were able to do is relax and coarsen some of the matching criteria, continuing to look at risk of symptomatic COVID in the first 10 days as the negative outcome control to ensure that we still seem to have a balance between the groups. In the end, we went with another geographic location that's a little bit broader than VA station, but still a marker of geographic location.
We have another question that relates to the generalizability, and I was wondering, like, you probably get the question, can you generalize the results to other populations outside the VA? But this question also asks, can you look at specific groups like the effectiveness of the vaccine in immunocompromised individuals?
Yeah. So because of the large sample that we had here, we were able in this particular analysis to look at certain subgroups here defined by baseline age and race. So commenting there just briefly, this is a very racially diverse population. So it's about 21% Black individuals in this population. And that's also a group of people who have been disproportionately affected by COVID, yet who are often underrepresented in biomedical research. And so we were glad to be able to provide evidence through that subgroup analysis. In terms of looking at subgroups of immunocompromised individuals as well, that's a possibility, just not something that we directly explored.
Thank you so much, Dr. Dickerman, and let me join in congratulating Dr. Dickerman for her work in the effectiveness of the vaccine.